Dr. Rubin, just unmute your microphone, please.
Got it. Okay.
Awesome.
Thank you so much, and it's a pleasure and an honor to be here today to speak with you. These are my disclosures. So I'm just going to give a very brief mention of some history about the parathyroid gland. It's actually the most recently discovered organ. It was identified in 1850 by a British scientist by the name of Sir Richard Owen, actually in the carcass of a rhinoceros. And you can see it exhibited to this day in a museum in London. And then in 1880, it was first described in people by a Swedish medical student by the name of Ivor Sandstrom, who didn't really get very much recognition for his discovery. And you can see his actual sketch here of the parathyroid glands in a person, but he didn't really know what their function was. And nobody really knew for a while until in 1925, a scientist by the name of J.B. Collip isolated some extract from a parathyroid gland and showed that it was able to reverse tetany that happened in a person who was hypocalcemic after having their parathyroid gland removed. Subsequently, in the 1970s, PTH was synthesized, and in 1991, the receptor that PTH binds to was able to be cloned. So we've certainly had a lot of progress in our understanding of PTH and how it works. And of course, we know very well that hypoparathyroidism is a state of hypocalcemia with inappropriately low serum levels of PTH. And the biochemical hallmark of the disease is a low blood calcium level, a high urinary calcium level, and a high blood phosphate level. We know that it's most commonly caused in adults from injury during surgery. This typically happens when patients have a complication from surgery to the neck for either thyroid or a parathyroid disease. It's also more common in patients who have more extensive neck surgery and who are being operated on by a surgeon who maybe has less experience. In terms of the non-surgical causes, there's many other types. Probably the most common of the non-surgical is genetic causes. So when we don't have enough parathyroid hormone, our calcium balance is thrown off, and this happens for a few reasons. The first is because we need parathyroid hormone to be able to reabsorb calcium that's being filtered by the blood through the kidney. So if we don't have enough parathyroid hormone, we're losing too much calcium that's going out into the urine and not remaining in the bloodstream as it should. In addition, if we don't have enough parathyroid hormone, the kidney is not able to increase an enzyme called 1-alpha hydroxylase. And that enzyme is responsible for converting regular or parent vitamin D into activated vitamin D. And if we don't have activated vitamin D, also known as calcitriol, then calcium and phosphate aren't able to be absorbed in the intestine. So that leads to there being a decrease in serum calcium as well. Finally, parathyroid hormone works at the bone to stimulate bone replacement. Normally, our bone is constantly removing old bone and putting in new young bone. And this not only keeps our bones healthy, but also provides a flux of calcium and phosphate from the bone into the circulation. So if we don't have enough parathyroid hormone, older, thicker bone accumulates and less calcium is available to be released from the bone to go into the bloodstream. So all of these mechanisms together, when they're not working because parathyroid hormone is absent, are going to lead to these deficiencies, namely a low serum calcium, a high urinary calcium, and a high serum phosphate level. And I don't really need to tell this group what the symptoms of hypoparathyroidism are like, because you certainly know them well and live with them constantly. But the common symptoms relate to those of the neuromuscular system being more irritable. And that means that there can be numbness and tingling, especially around the mouth or in the fingers and toes. There can be paresthesias, which also means kind of pins and needles. There can be very distressing muscle spasms, generalized weakness, and very distressing neurocognitive deficits. More serious symptoms can also occur. These can be cardiac abnormal heart rhythms. There can be spasm in the larynx, which can be extremely dangerous, and there can be tetany and seizures. And there are also long-term complications which can develop. This was a large study in Denmark where all patients are logged into a health registry. And what we see here is that this line at 1 is how things should be if they're similar to in the normal population. But if we look at where patients with both surgical hypoparathyroidism in red and non-surgical hypoparathyroidism in blue fall out, you could see that many of these things are occurring over to the right of the normal line at number 1. So particularly we can see how there's an increase in psychiatric complications, in seizures, in renal disease, and in cataracts. Fortunately, from this study, it doesn't seem to be that there's an increase in mortality with hypoparathyroidism. But clearly there are many long-term complications that we worry about. And I just want to highlight in particular these long-term complications, which include ectopic calcifications, and that means calcium being deposited in places in the body where it normally shouldn't be. And we think this happens especially when if you multiply the blood calcium level times the blood phosphate level, if that level is too high, we call this the calcium phosphate product. And we think that having a high level of that is a particular risk factor for these calcifications in places that they don't belong. And I also want to give a special emphasis to nephrocalcinosis, which means calcium building up in the kidney, and nephrolithiasis, which means kidney stones, and then general renal dysfunction, because we really worry over the years that the kidney function becomes compromised in people who have hypoparathyroidism. So the conventional way to manage hypoparathyroidism is one that you're very familiar with. We also call this standard of care. And the backbone for this is, of course, to take calcium both from diet and supplements. We can use calcium carbonate, calcium citrate, and other supplements. We also use activated vitamin D because we don't have the normal effect of PTH to stimulate the conversion from regular or parent vitamin D to active vitamin D. In this country, the usual type of active vitamin D that's used is called calcitriol, but in Europe, it's common to use alpha calcidiol, which is another form of vitamin D that can become activated by the body. We also use as part of our standard management parent or regular vitamin D because we know even in the absence of PTH that it's important for other tissues, and some tissues actually are able on their own to convert parent vitamin D to 125 dihydroxyvitamin D or the activated form. So it's very important to have sufficient levels of parent or regular vitamin D. Sometimes it's helpful to take magnesium because that can help to prevent low calcium levels. And sometimes it's also helpful to take a thiazide diuretic like hydrochlorothiazide or chlorthalidone because these medicines can help to increase calcium to be reabsorbed at the kidney. And it's important to note that these medicines are really effective only when dietary sodium intake is low. So these are our conventional or standard tools to manage hypoparathyroidism. And they do work, and we certainly rely on them heavily. They increase intestinal calcium absorption, and they do correct hypocalcemia, but they don't really correct the underlying deficit that occurs in the disease. So without having the effect of PTH to hold on to calcium in the kidney, we're going to lose calcium into the urine and have a high urine calcium and not have enough calcium in the blood. Even with conventional management, we can still get swings of calcium with hypo and hypercalcemia. Our conventional management does not help with reducing the so-called calcium phosphate product, which we think is a risk for abnormal calcifications. And then our standard management does not really help with the long-term complications that we worry about, like calcium depositing in the body, calcium depositing in the kidney, kidney stones, or renal dysfunction. And of course, importantly, the conventional therapy, it might help somewhat with quality of life, but does not seem to restore it to a normal level. So even though we count on this standard of care, it falls short of optimally addressing the problems with hypoparathyroidism. So it makes sense, of course, to turn to PTH therapy. And after all, hypoparathyroidism for a long time was the last remaining endocrine deficiency disease that didn't have treatment with which the missing hormone was being replaced. So if somebody has diabetes, of course you would give them insulin. If someone has hypothyroidism, of course you would give them thyroid hormone. But for many years that was not available to be done. In fact, it was first tried many years ago. A scientist by the name of Fuller Albright, who's thought of as one of the founding fathers in calcium and bone disease, actually in 1929 treated a young Italian boy at Johns Hopkins who had hypoparathyroidism. At age 5, he had had his parathyroids inadvertently removed when he underwent a tonsillectomy. And for the subsequent 9 years, he had suffered with severe hypocalcemia with calcium levels in the 5s, phosphate levels in the 10s, and almost unremitting tetany. And you can see here from this very old article how his calcium level was 5.0, his phosphate level was 10.7. But Dr. Albright actually used that PTH extract that I mentioned in the beginning that was obtained by the scientist J.B. Collip. And over time, this young boy's calcium started to rise, his phosphate started to fall, his calcium subsequently went up into the 8s, and you can see that his persistent tetany and abnormal Schwastek sign, which is a sign of hypocalcemia, subsequently resolved. But it wasn't until 86 years from then that parathyroid hormone was actually approved by the FDA in 2015 as an adjunctive therapy for patients who had hypoparathyroidism and were refractory to conventional management. And this, of course, was a total watershed moment in the treatment of hypoparathyroidism. Nevertheless, even having PTH therapy is still far from ideal because the way it has been administered is as a once daily or twice daily shot. And this is a very old paper to show that normally PTH levels have to be present at least at a constant level in the body and sometimes even going higher than a constant level. In this study, 4 lab technicians were recruited to have their PTH levels measured every 2 hours for a 24-hour period. And you can see how each of them had constant or what we would call basal levels of PTH. And in fact, they even rose at night and seemed to peak between 2 a.m. and 4 a.m. So this makes the point that we really need to have at least constant levels of PTH around, and sometimes maybe even adjustments or increases in our PTH levels, and that a once or twice a day injection is not going to be physiologic. And this point is also shown by this detailed study where PTH 1 to 84 was given. This was a 100 microgram dose of Natpara that was given. And you can see in the first few hours here, kind of in this purple, that PTH levels do indeed go up, but then they start to come down over the subsequent hours. And 12 hours after a PTH shot, the levels of PTH are in fact undetectable. Now, calcium does have a delayed increase, and you can see that it rises and peaks at about 12 hours after a PTH shot. But again, after 12 hours, it does start to drift downwards. And even though at the 24-hour point, the calcium level is still higher than it was to begin with, you can see that it's on a downward trajectory and not remaining at an elevated normal level. And Dr. Karen Weiner at the NIH noted a similar phenomenon. She gave patients PTH shots. This was 1 to 34, but you could see here how right after the shot, the urine calcium level shoots up. And then subsequently, it starts to fall as we want it to, and that's because the effect of PTH to reabsorb calcium at the kidney starts to kick in. But then you can see how that starts to wear off, and the calcium level in the urine starts to rise. So you can imagine if somebody is getting a once a day or twice a day shot of PTH, that there might very well be these early spikes in urine calcium levels above the normal range that potentially over time might be damaging to the kidney. So this really emphasizes the point how we want to be able to have a continuous level of PTH. And Dr. Weiner took this a step further because she actually gave PTH to patients in a continuous manner. So she took insulin pumps, but instead of filling them with insulin, she filled them with PTH and gave them to patients to wear. And what she found was that there were continuous levels of PTH, and this worked to normalize serum calcium levels and reduce fluctuations of hypo and hypercalcemia. Also reduce the urine calcium excretion by about 60%, lowered the serum phosphate level, and normalized bone remodeling, because we know that bone replacement is very low when we don't have PTH, but by giving it continuously, she brought it up into the normal range. And all of this was done, in fact, by using 60% less than the normal amount of PTH that would have been needed to be used for an injection. So this showed in a very compelling level that continuous exposure to PTH is very physiologic and is able to restore the biochemical balance in patients who have hypoparathyroidism. So the idea behind TransCon PTH really builds on this knowledge. And the way the drug actually works is that regular PTH 1 to 34, which is shown here by this little orange curly piece, is used, but it's wrapped around in the TransCon carrier. That's this blue ribbon, which is attached to the PTH by this green linker. And what happens is that the TransCon is only transiently conjugated or only temporarily bound to the actual PTH. So while it's still attached to it, when the PTH is first injected, it's shielding the PTH from being able to attach to the PTH receptor and unleash all of its normal effects. But in the setting of normal body pH and normal body temperature, this little green linker changes shape so that the TransCon carrier gradually separates from the actual PTH. And this leads to there being a sustained, persistent, continuous level of PTH that's being maintained in the circulation. So this was first tested out, of course, in animals, and it was looked at in rats, both who had normal parathyroid function and rats that were hypoparathyroid. And then it was looked at in monkeys who had normal parathyroid function. And it was shown that giving the TransCon PTH led to all the effects that we would want PTH to do. Namely, it was able to increase calcium levels, it was able to lower urinary calcium levels, and lower serum phosphate levels. And the authors who did this investigation actually did some modeling to compare what PTH levels were like if you give the 1 to 34 as a twice a day shot, as seen here in the red, and you can see that there are these spikes of a dramatic increase in the PTH level, which then come back down to be undetectable and then repeat, as opposed to the PTH levels that were seen with the TransCon, which remained at a persistent, continuous, normal level without these sharp up and down spikes, thus making the point that with this longer acting form, a continuous, virtually infusion-like profile of PTH was able to be achieved. So taking it on from animal studies, the next step that was done was a phase 1 trial. And this is how we first look at a medicine to test its efficacy and its safety in healthy volunteers. So these were people who had normal parathyroid function who got shots once a day of TransCon PTH, and you can see they got different doses. This black line was the lowest dose and the purple line was the highest dose. And you can see that all of them had PTH levels that were above this dashed line, which represents the lower limit of normal PTH levels. And what's really impressive is you can see that the PTH has this completely flat profile. So it's not with these up and down spikes, but it's really as though the patients are getting a continuous infusion of PTH. And in fact, the half-life of PTH here was found to be 60 hours. So an extremely long, stable half-life. So the next phase after doing a phase 1 study was to go on and actually test it in people who have hypoparathyroidism. And that's what the phase 2 study was about. So this was to demonstrate that the medicine would be safe and effective in adults with hypoparathyroidism. And the way the study was designed was that people who were in the study were randomly assigned to one of 4 groups. 3 of the groups were different doses of PTH, either 15 micrograms a day, 18 micrograms a day, or 21 micrograms a day, and 1 group of patients was assigned to placebo. And the patients didn't know what they got, and the investigators didn't know what they got either, although of course we could guess based on how the patients were doing. And the primary composite endpoint, or in other words, what was decided beforehand would be meaningful as showing that the medicine was working, were these 4 things that were sought to be achieved at the end of 4 weeks. The first was to show that the participants would have a normal serum calcium. The second was to show that the participants would be able to completely stop taking vitamin D. The third was to show that the participants would be able to take 1,000 milligrams a day or less of calcium. And the fourth was to show that this measure of urine calcium, known as the fractional excretion of calcium, would go into the normal range or at least decrease by 50%. And if those 4 things were met, it was felt to be that the drug would be proven to be effective as a treatment for hypoparathyroidism. In addition, there was a more strict secondary endpoint, which was to show that not only would participants be able to go down to 1,000 milligrams a day or less of calcium, but even to go down lower to 500 milligrams a day or less of calcium. So this was the goals that were set for this 4-week double-blinded study. So there were 59 patients who participated in it. The average age was 50. Most, 81% of the participants were female. Most of the participants had hypoparathyroidism because of a post-surgical cause. The average duration of having had hypoparathyroidism was 12 years. And the regimen showed that the average amount of calcitriol was 0.75 micrograms a day that was being taken, or alpha calcidiol 2.5 micrograms a day. And the average amount of calcium supplements that were being taken was 2,000 milligrams a day. So this was clearly a representative cohort.
Excuse me, Dr.
Yes.
Dr. Rubin, we have 5 more minutes before
okay.
4 questions.
I'm sorry, I thought I had till 4:15, but I'll talk quickly. I apologize.
That includes questions.
Okay, no problem. So basically, the results from the 4-week study were highly significant and positive, and 50% of the patients in all of the TransCon groups met the primary endpoint, and all of the patients in the highest dose of the TransCon group met the endpoints. Moreover, 45% of patients in the TransCon groups even met the stricter endpoint of being able to go down to 500 milligrams of calcium, and that was met by all of the patients in the highest dose of the TransCon group. And TransCon PTH was shown to be able to eliminate what's known as the standard of care. In other words, patients no longer needed any active vitamin D, and they were able to go down to less than or equal to 500 milligrams a day of calcium in 82% of the subjects and in 100% of the subjects in the highest dose group. So another way to say it is that 50% of the subjects in all 3 of the TransCon PTH groups were even able to completely eliminate standard of care. They actually needed no more vitamin D or no more calcium by the end of 4 weeks. There was only one person who dropped out. And this is just showing pictures of it. You could see that the active vitamin D came down within 2 weeks in the patients who were on TransCon, whereas there was no significant change in the placebo. And you can see that calcium doses in the colored lines came down by 2 weeks to less than 1,000 milligrams as opposed to placebo, and then came down even further in week 4. The reason in this group in 18 micrograms it didn't continue to come down was because one patient was frightened of stopping the dose of calcium that she was on. Other important things were that the serum calcium increased, urinary calcium decreased, phosphate decreased, and this marker of the calcium phosphate product decreased. And the safety was very reassuring. There were no serious or severe adverse events that occurred. So this 4-week study showed that the majority of patients who were on these doses were able to completely stop vitamin D and able to take less than or equal to 500 milligrams of calcium, along with the serum phosphate and the urinary calcium coming down to normal. So I'll just very quickly go through the next part, which was the open label extension, which is that all of the patients who had been in the study for 4 weeks were then invited to continue with getting PTH titrated to the dose that was appropriate for them. And the markers for success for this part of the study, known as the open label extension, were a normal serum calcium, to be completely off of active vitamin D, to take less than or equal to 500 milligrams of calcium, and to have a 24-hour urine calcium that was normal or 50% reduced from baseline. And you can see here that 35 out of the 58 patients, or 71%, met all of the criteria for response, which are listed below. And just showing what that looked like, you can see the patients who were on TransCon from the beginning had that drop to not needing vitamin D anymore, and the patients who had started out on placebo, once they switched to TransCon here, had the same drop, and they remained off of active vitamin D. Similarly, the patients who were on TransCon from the beginning had the drop in calcium supplements, and those who were on the placebo at first, once they got on TransCon PTH, had the drop in calcium supplements also. Serum calcium rose and stayed within the normal range. Serum phosphate and the calcium phosphate product decreased. And of course, very importantly, 24-hour urine calcium level decreased. So here's the patients who were on TransCon from the beginning, and you could see just how high their urine calcium levels were in the 400 range. But after the 6-month extension study, the urine calcium came down well safely into the normal range. The patients who started on placebo and switched to TransCon had similar results, and this is showing everyone together. So the 24-hour urine calcium did decrease by 57% into the normal range. It should be noted that 10 patients did not have their 6-month urine calcium included for various reasons like laboratory problems, but nevertheless, these results are still very important. There was a range of doses that the patients needed to use, but the most common dose was 18 micrograms, and there was a very high level of compliance. One interesting thing to note is the patients who weren't able to meet all the criteria of success. And I just circled here 3 patients who still had very high urinary calcium levels at the end of the 6 months. And it would be interesting to look more closely to understand that. For example, this patient here wasn't on any calcium or any vitamin D, but nevertheless still had a high urine calcium, and I'll come back to that in just 1 second. This shows that quality of life as measured by the very reliable SF-36 questionnaire improved in all patients who were on the TransCon, not at first in the placebo patients, but then eventually when the placebo patients changed over. And lastly, I just want to make the point about bone turnover, because we saw that bone remodeling or replacement increased, and this is important because there's abnormally low bone remodeling in patients with hypoparathyroidism. And we can see with TransCon that the bone formation, known as P1NP, increased by about 150%, and bone resorption increased even more by about 350%. And I think we don't fully know exactly what that means. You know, on the one hand, it's certainly a good thing because hypoparathyroid patients have an accumulation of overly dense, hypermature bone. So we do want to see that bone is being removed. But I think it'll be very important to see in the long term whether any bone loss that's excessive is occurring, because of course we know in the opposite disorder, primary hyperparathyroidism, when there's too high continuous levels of PTH, that bone loss can occur. But I think we'll look at the bone density and then we'll know the meaning of it. And I also wonder if perhaps there was high bone removal in those patients that I showed previously who had high urine calcium. Maybe the old bone being removed was causing a flux of calcium into the body, and then the body was getting rid of it through the urine calcium. There were no serious or severe adverse events that occurred that led to a visit to a hospital or an emergency department. And I'm just going to end by mentioning the phase 3 study, which right now is in the planning stages and being presented to the FDA. This will, again, at first be a randomized, double-blind, placebo-controlled study. So 3 out of 4 patients will get assigned to TransCon PTH. 1 out of 4 patients will get assigned to placebo. And this will be the protocol for 6 months. It's planned that 76 adults will be included, and the starting dose will be 18 micrograms. And then there will be an open label 3-year extension where everybody will be able to continue on the dose of TransCon PTH that they need. So to end, it's clear now that continuous PTH exposure is a highly physiologic treatment for hypoparathyroidism, and TransCon PTH appears to provide that in a safe and effective way. We do still need more data to be able to investigate the long-term effects of TransCon PTH, including effects on complications. Does it prevent or reverse kidney damage? What are the long-term skeletal effects? And the phase 3 study will be certainly illuminating in this regard. So I want to thank the participants and their families. We've been fortunate to have a group of patients at Columbia who've been able to do this study, and we know it represents a big commitment to be able to do it, but it is our hope and our realization that it's moving the field forward. So I'm going to stop now and hopefully have enough time to take questions.
Okay, you did great. So, what is the best way of assessing and monitoring calcifications?
Yes, so certainly we would want to look at the kidney. We could look at that by kidney ultrasound. You could look at that by other kidney imaging like CT. We do know that calcifications builds up in the brain, in particular in an organ known as the basal ganglia, and the best way to image that would probably be by a CAT scan. Unfortunately, there isn't really systematic data available for just how frequent that is, but looking at the kidney imaging and possibly the brain imaging would probably be the best ways to monitor for that.
Okay. And then a question came about, what is the difference between the TransCon and NatPara?
Yes. So first of all, NatPara is PTH 1 to 84, which is the full PTH molecule. And TransCon is using the 1 to 34. But the main difference is that NatPara, once it's injected, it does have a longer half-life than regular PTH 1 to 34, but it does seem to lead to a relatively quick increase in PTH levels and thus calcium levels, which peak maybe at about 8 to 10 hours after injection, maybe 12 hours, but then start to drift downwards. So that by 24 hours, it can be that patients feel low and are perhaps hypocalcemic. The TransCon PTH, because it has this sustained release mechanism so that it's slowly and continuously being released, is leading to a stable, continuous, normal level of PTH. It has a very long half-life so that there isn't the ups and downs that might occur with NatPara.
Gotcha. And then the question came in about, is the TransCon related to Forteo at all, or how does that relate in all of that?
Yes. So in a sense it is, because TransCon is using the PTH1 to 34 molecule, which is the same thing as Forteo. But if we just give Forteo, which certainly has been used effectively in patients with hypoparathyroidism, it lasts for only a very short time and probably needs to be injected 2 or even 3 times a day. The TransCon is using that same PTH1 to 34 molecule, which is Forteo, but because it's wrapped in this carrier, it's allowing for a slower, delayed, prolonged release of the 1 to 34 PTH into the circulation. So the PTH molecule, the 1 to 34, is actually the same as the Forteo, but the body is being exposed to it in a different manner.
Okay, and let's see. Can people on Forteo currently join the TransCon study after a washout period? If yes, how long would the washout period be?
So I know that it is going to be allowed after the washout period, and I'm going to refer you to Ascendis, because I know that they have an exhibit as part of the conference where they're going to provide detailed information about the upcoming phase 3 trial. So I think they would have the information. I don't want to misspeak about exactly how long the washout period needs to be.
Okay, let's see. I'm trying to see if we have any brand new questions coming in here. Is bone density being measured in the trials?
Yes, it is being measured in the TransCon PTH trial. You know, it's an endpoint that it takes some time to see change in it. So the data that we have so far from the phase 2 study aren't really long enough for us to see the changes yet in bone density. But I do think it'll be interesting and important to see those results, which will be available as the extension part of the phase 2 study proceeds.
Okay. Was there a difference between genetic versus surgical hypoparathyroid patients?
So to my knowledge, that wasn't looked at. I don't know if the number of participants was big enough to say that. The majority of the participants are post-surgical patients. So my suspicion is that the number of genetic patients would be too small to be able to parse out a difference. But I do think that is something important to be looked at in the future.
Okay, very good. And then there was a question about the levels that peaked like in the middle of the night, the 2 to 4 a.m. Can you share, should there be any adjustment or different ways of taking the calcium because of that?
Yeah, I think we don't really know. I think it's clear that there is what's known as a circadian rhythm to PTH secretion, and that it does physiologically go up, you know, at these times of day and then also come back down. I think the physiologic significance of that is unknown. You know, intuitively, it's appealing to say that we should try to mimic physiology as closely as possible so that we would want PTH levels to be higher at that time. But I don't think that the data are there to show that that's something that's necessary in order to have optimal health for all of the outcomes that we care about. So I don't think that's known.
Okay, and then just a couple closing things, like when is the estimated date of the phase 3 trial to be approved, and when do you anticipate potentially being on the market?
So again, I think I'd have to defer to Ascendis for that. I do know that there's a lot of rapid and hard work going into it. I do think the phase 3 study is going to be ready for enrollment in the near future. You know, I hope that the drug will be available in the market soon, but you know, I can't really know enough to give you a timeline. I do think the Ascendus team maybe would be able to give a little bit more precise information about it.
Okay, very good. Bob or Deb, did you have any additional questions that you wanted to ask as a last minute question here? I know we have a lot of them in the queue that we'll get back to after we get done with the sessions.
Well, I just want to say that I'm happy to be emailed by patients with any questions. My email is mrr6@columbia.edu. So I'm certainly happy to answer whatever questions there are that I wasn't able to cover.
Yes, and we're going to send all these questions to you as well, Doctor. Colmeyer. Yeah. So what? No, I'm sorry about that. Anyways, yeah, we'll send these questions to you.
All right, Dr. Rubin, thank you truly so much. I am very fortunate to be a patient of yours, and I'm so happy for you to be able to share all this stuff with everybody as well. So thank you so much for your time, for all your efforts, before the conference, after the conference, and we appreciate you.
You're welcome. It's a real privilege. Thank you.
All right. So everybody, we're taking a few minute break here before we see our next presenter. So get up, stretch your legs, grab a drink, and we'll talk to you real soon.